Breast cancer risk factors, personal history with or without genetics. Some women develop breast changes, and a lot of these changes are normal and not cancerous, such as when a woman ovulates or when she is pregnant. Some changes are just about the structure of the breast, which are not cancerous in and of themselves, but they may still increase her risk for cancer. Here is the anatomy of the female breast and possible lesions it may develop. As you can see, it depends on where the lesion is coming from, whether it's from the main duct. They can develop benign findings such as a papilloma or ductal hyperplasia, or if it's coming from the lobule, you can develop cysts, sclerosing adenosis, fibrocystic changes, and a fibroadenoma. But again, all of these changes are walled off and benign. However, if you have a personal history of different kinds of breast disease, it might increase your risk of cancer. Of course, if you have a history of breast cancer of any type, your further risk is increased. But even non-cancer, such as ductal carcinoma in situ and lobular carcinoma in situ, which can increase your risk by a lot, although there are other kinds like atypical ductal hyperplasia and hyperplasia of usual type, as well as sclerosing adenosis that have slight increases in your breast cancer risk. Here are the numbers behind those relative risk factors for breast cancer. As you can see, LCIS and DCIS there at the top have 16 and 17 relative risk increases. And then all the way down at the bottom, I just wanted to point out BRCA gene definitely has a 200 relative risk factor for cancer. Why is DCIS different? There's a bunch of different theories about how DCIS comes to be, but the main point that we want to get across is that the prognosis is excellent. While DCIS does not equal cancer, it does increase your risk of cancer, but the prognosis in and of itself is awesome because we can just cut it out. Let's move on to genetic risks.
When considering genetic mutations in breast cancer, there's both high penetrance and moderate penetrance genes. You can see these listed in these separate categories here. The high penetrance genes, including BRCA1 and BRCA2, can be associated with up to 80% lifetime risk of breast cancer development, whereas the moderate penetrance gene mutations are associated with up to twofold increase in lifetime risk of breast cancer compared to the average risk population. So who to test for genetic mutations? Patients that are diagnosed with breast cancer under the age of 50 or at the age of 50, males with breast cancer because it's unusual, Ashkenazi Jewish descent patients, triple negative histology, lobular histology in someone with personal or family history of diffuse gastric cancer, multiple primary breast cancers. They can be both at diagnosis or at different times, history of ovarian or fallopian tube or peritoneal malignancy, exocrine pancreatic cancer, metastatic prostate, or high-risk prostate at any age, relatives with a history of BRCA or other high or moderate penetrance genes like we just discussed, as well as a concerning family history. Another important population to discuss is patients who have had ionizing radiation to the chest. So you'll most often see this with patients who have a history of treatment for Hodgkin lymphoma with radiation. You'll also see this, though, in a smaller population of survivors of atomic bomb or nuclear plant disasters. So the cumulative incidence of breast cancer development is up to 13 to 20% by age 40 to 45. For Hodgkin lymphoma survivors, the risk increases the incidence almost by 35% by age 50, which is comparable to a BRCA gene carrier. The most vulnerable population is pre-puberty radiation exposure, so from 10 to 14 years old. Breast cancer risk increases with increasing radiation dosing, but the histology of the breast cancer that these populations get looks just like the general population histology. So why does radiation increase a woman's risk of cancer? So radiotherapy causes an induction of DNA damage, and over time, this DNA damage allows for potential for abnormal cell proliferation. At the end of the day, all cancer really is abnormal cell proliferation. So when considering who is at risk, what is an important amount of radiation dosing to consider increased risk of breast cancer development, there is a 2020 guideline For the breast cancer surveillance recommendations for female survivors of childhood, adolescent, and young adult cancer from the International Guideline Harmonization Group that put out multiple recommendations. So, one being a strong recommendation to perform breast cancer surveillance on survivors that were treated with greater than or equal to 10 gray chest radiation. So, gray is the dosing of the radiation. There's no recommendation included for routine surveillance of survivors treated with less than 10, so 1 to 9 gray. There's a moderate recommendation to perform breast cancer surveillance for survivors treated with upper abdominal radiation that might expose breast tissue at a young age. There's also a strong recommendation to perform annual surveillance for patients up to age 60, and then a moderate recommendation to continue that for patients older than 60. And then there's also a strong recommendation to perform mammography or breast MRI or a combination of those. So in summary, there are non-cancerous breast changes that can lead to increased risk of breast cancer. It's important to consider genetic mutations that can also increase risk of breast cancer, sometimes as high as 80% lifetime risk. It's also important to note that ionizing radiation, especially at a younger age, puts patients at a higher risk of breast cancer development later on in life. 1 in 6 breast cancers occurs in women in their 40s. Mammography has helped reduce breast cancer mortality in the U.S. by nearly 40% since 1990. One study shows mammography screening cuts the risk of dying from breast cancer nearly in half. 1 in 4 women diagnosed with breast cancer have no family history, are not considered high risk. ACR guidelines state that screening prior to the age of 40 has been recommended for women with a family history of breast cancer diagnosed before age 50. So keep in mind that would mean starting mammography at the 10 years prior to the age of diagnosis of that particular family member. However, not before the age of 30. This high risk of prevalence is why it's so important to know who is at a higher risk and who needs to be screened so that our patients in the UT system are not at a disadvantage. Breast cancer is on the rise and happening in younger women with or without family histories. Thank you for your time. There's a post-test survey if you would be as kind as to fill that out for us.